All right, good afternoon, everyone. Thank you so much for joining us for our webinar today. My name is Sarah Eaglesizer, and I'm the clinical implementation nurse with OPEN, the Overdose Prevention Engagement Network. We are so happy and thrilled to welcome you to our webinar, When Clinics Close, Strategies for Managing Patients on High-Risk Medications. I'm just going to do an audio and screen share check. Everything good from our team? You can hear me okay? My screen looks good. So during our presentation today, audio and visual capabilities for participants will be turned off. We do ask, encourage you to ask questions of our presenters. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. We will address these questions at the end of our presentation today. We are offering CME credit, and we'll have a slide up about how to obtain those credits at the end of our webinar. We will also email this information out to you as follow-up. So our agenda, we will do a quick overview of our organization, review data related to the Michigan Pain Consultants clinic closure, discuss some challenges that patients and clinicians face, and then go through some best practices for managing and stabilizing patients with controlled substance prescriptions. We do not have any disclosures. So the Overdose Prevention Engagement Network, or OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce the harms and stigma around substance use, we work to support healthcare clinicians and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts. We offer expert-led education and training sessions. Most of our webinars include free CME, CEU, and McBack credits, and for prescribers, qualify for the DEA required SUD training. We also provide MOUD training for clinicians, including physicians and advanced practice providers. And this year we are incentivizing primary care clinicians with a $250 incentive to complete one of our trainings. The next one will be coming up in September. And to prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing practices. You can access more information about all of these offerings using the QR codes on the screen or visiting our website. In addition, OPEN offers tangible tools to reduce the harms of opioid and substance use, and our hope is to disseminate these resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for patients and clinicians. We provide safe medication storage and disposal options. And we also offer overdose rescue trainings and naloxone distribution boxes and vending machines. So with that, I will go ahead and turn it over to Dr. Chris Frank and Dr. Chad Brummett to introduce themselves and begin our presentation today.
Thanks, Sarah. So I'm Chad Brummett. I'm an anesthesiologist, a pain physician, one of the co-founders of OPEN. And Sarah, I realize we put this together kind of quickly, and we do need to update. I do have disclosures. I consult for Merck Pharmaceuticals, Vertex Pharmaceuticals, previously consulted for Heron and other companies, and I do some expert testimony. I don't think it's related to today, but I put it out there just for full disclosure. We can update accordingly. And I'll let Chris introduce himself in here in just a minute once he gets going. Can I get the next slide, please? So why are we here today? You know, this has been a situation that came up a couple of months ago. There's been a lot of work around the state from different organizations to address this. The Michigan Pain Consultants was a large pain clinic on the west side of the state, sort of in the Kent County, Grand Rapids area, and north of there. The total number of patients is still not completely clear to me, but I'm told about 50,000 patients. And as with anything, if you have a pain clinic there is a closure for whatever reason, this can lead to disruption. And in particular, while the procedural care can be disrupted, the loss of procedural care can be disruptive to patients. The most concerning for patients and providers is our patients on controlled substances, specifically opioids and/or benzodiazepines being used for pain. And so our goal here today, based on requests from primary care providers and others on west side of the state, was to give some information on how to best manage this situation, which is, physicians are naturally going to worry about what's hard about this for them. But I want to really reiterate, and I think Chris is going to talk about this too, this is a really challenging situation for the patients themselves and their family. And I think that was something that Chris brought up in our conversation yesterday in preparation for this that I think is just so important and needs to be emphasized multiple times. So in order to try to provide some light, to sort of shed some light on the situation, we used data from IQVIA. Our group works with IQVIA. IQVIA is a pharmacy fulfillment database, largely used by pharmaceutical companies, but we use it for academic purposes. IQVIA captures about 92% of the prescription fulfillment in the United States. And we looked up the providers within Michigan Pain Consultants. We matched back to their addresses and basically picked up the 21 prescribers who have been prescribing controlled substances in the state of Michigan in this calendar year. We basically then took the last quarter of data available, which was March 1st through May 31st. And this is what we found. I think the good news here is that the dosing is fairly modest. And the reason I say that's good news is because anytime you're going to have an acute change, primary care physicians who may not be prescribing a lot of opioids, if handed a large cohort of people on really high doses, that can be even more challenging. I think the short note here is that the prescribing was pretty modest. We do have some outliers. We do have some on the higher end. I think that does confer some level of risk. And I'll acknowledge that even maybe our titling of this seminar in terms of high-risk medications, I don't really think about all opioids do carry some risk, but we need to acknowledge that there is risk with acutely ceasing these opioids, and Chris will talk more about that. We see a mean dose of about 35 milligrams, morphine milligram equivalents. That's the equivalent of about, say, 4 or 5 milligram oxycodones per day or 7 hydrocodone 5 milligram tablets per day. Only about 2% of the people were on opioids and benzodiazepines overlapping, 18% on more than 50 MME per day, which is one of the thresholds the CDC guidelines put forward for sort of higher risk. And then the original sort of risk cutoff in terms of guidelines for the CDC was 90 milligrams per day. There's only 3.8% of the people. It's about 4,500 patients total who were on controlled substances from Michigan Pain Consultants over this quarter. We see that the higher daily doses were more common in Medicare. The data you see there, those averages, those hold up for private insurance. Private insurance is almost exactly those averages that you see there, and actually slightly lower doses in the Medicaid insurance population. And so what have we done? We have been working with a number of organizations across the state for a few months. Since this came up starting in June, a group within Michigan Department of Health and Human Services that convened a group of providers from across the state, in particular on the west side of the state. We worked with a primary care collaborative on the west side of the state who is interacting directly with PCPs in the community, as well as the Blue Cross Blue Shield of Michigan Value Partnerships. We put forth communications, including information, like most of what you're going to see today was put forth in an email blast in order to try to get information out there. And then we're continuing to provide education and consultative services, and Chris will talk about those consultative services. I will acknowledge, and I think it's really important to acknowledge that we're not the only ones doing work here. Corewell Health has been working very hard on this, as have other private clinics in the west side of the state. Corewell Health has taken on a number of patients, not necessarily every patient, but they also offer, and we can reiterate this later, but for those Corewell health providers, primary care providers or otherwise, there is a consultative service available to you through Corewell. You put in an inbox note, and they will do some curbside consulting. If you're in a position where you're not able to get the person in for a referral, but you need some help, that is there and available today. And I was just communicating with folks at Corewell today about that. So there has been a lot of effort to try to address this situation, which is, a major challenge. I have not seen a clinic of this size close. It was done over the course of months, but even with that being done over the course of months, we're told that there were some clinics that closed acutely, meaning that some of this disruption has been going on for a couple months, and the clinic itself closes in full at the end of this month. So with that, I'm going to hand off to Dr. Frank and let him start to give you a little bit more information.
Excellent. Thanks a lot, Chad. Well, I was going to say it's great to see everyone today, but I can't actually see anyone, but I'll assume that you're there on the end. I'm a family doc and addiction medicine specialist. And I think I'm here today probably because I've gone through a few of these kinds of things myself in my own practice. And I hope we can give you some resources, but I think we should start by just acknowledging that these are really difficult situations. I think anyone who's been in practice for more than like a minute has had the experience of seeing a new patient in your clinic and kind of looking at a medication list and having a sort of sinking feeling in your stomach because maybe you can tell already that that this is potentially going to be a more challenging situation, or maybe someone's on medications that you are not comfortable with or haven't used a lot in the past. And so I think we've all been in those situations. And I know Chad mentioned that, anytime it's a big situation like this, I was involved in one large group of pain clinics that closed in Washington State. It always creates a lot of really kind of chaos and fear, right? And thankfully, most of that doesn't tend to come to fruition, but it's still there. But I think as sort of difficult as this is for clinicians, I think it is important to remember that oftentimes for patients, it's quite a bit worse. Really not very many sort of clinical situations where patients are stigmatized as in chronic pain settings, but also in substance use disorder settings. And so most patients have been bumped around, kind of hot potatoed through the medical system before they landed somewhere. And so they often have experiences where they've been abandoned or felt abandoned. And this is often a really, really stressful situation for them because they may have found help from the medications they're taking, or even if they haven't, they may have emotional attachment to them or have developed an iatrogenic substance use issue. And so people are really stressed. And the one thing we know is when people are stressed, we often don't see them at their very best, kind of similar to when we're stressed at work. Maybe people aren't always getting our very best. But we know that mental health conditions, pain, and substance use disorders all get worse with stress. And it's one of the reasons that oftentimes the first time we see people in these situations, the interactions can be challenging because both sides, both clinicians and patients, are feeling maybe not at their very best and are feeling under some pressure. So I just wanted to start with that acknowledgement. This is difficult, but the good thing is that I think there are some ways forward through these situations that can be positive experiences for clinicians and patients, and can sort of lead into longer term relationships with patients that get them better, sometimes better care, sometimes the same care, but at least care that where everyone feels like they're meeting both their professional needs and the patient's needs. So the big issues tend to be that this disruption in care, where people are worried about either running out of their medications or they have run out of their medications can lead to a bunch of negative downstream consequences. So, stopping benzos, I think that one probably everyone knows is dangerous. Abrupt discontinuation of benzos kind of works in a similar pathway as abrupt continuation of alcohol. And so that it not only doesn't feel good, it's also dangerous. And then similarly for opioids, stopping opioids for most people who are taking them on a chronic basis, even if their doses are not that high, many people will experience pretty significant withdrawal symptoms that are very unpleasant. And while I think sometimes just think of it as unpleasant, I think we're going to talk a little bit about some of the evidence showing that it's not really just unpleasantness for some folks. There are some real harms that can happen from abrupt discontinuation of these medications without a plan to manage people's symptoms or their long-term care. So I think there are a few basic steps that we can take to ensure patient safety. And one of the most important, this is just me, so and I think there are many different ways of doing this, but I think one of the things that I've tried to do is remind myself that not everything needs to be done in the first time you're meeting someone. And so oftentimes these situations, people have a long history of pain. They've been through many different treatments. They've been through many different medication trials. And sometimes if we try to bite off all of that in one visit, it can be quite overwhelming, both for us and the patient. And so I think, really starting out at a fundamental level of just confirming what medications people are actually taking. And thankfully, we have a good PDMP in Michigan. A lot of people obviously have it integrated into their electronic health record. So I think a good first step is really getting a strong handle on what medications people are taking and checking that against the pharmaceutical data so that you have a good understanding of how often people have been filling it, how much they're using, and what other clinicians might be involved in their care that you might not know about. And then I think the other thing that is often helpful early on is, you're going to have some discussion about risks, benefits, and alternatives to their current medications. But one of the things that seems to depressurize these situations is an early acknowledgement that you're not just going to do something and abruptly cut somebody off from medications that they've taken for a long time. And I think that can be uncomfortable for us because sometimes they might not be the exact medication choices or the doses that we might have chosen. But essentially, when these happen to communities of clinicians, if people are punting, it can really create a lot of churn in the system where patients are jumping doctor to doctor to doctor to doctor, finding someone who's going to stabilize their situation. It can create a lot of work. And so sometimes it's easier just to take a breath, focus on stabilizing people, making sure that their acute safety needs are met, and then taking the long-term approach. I think of it a little bit like when patients are coming out of inpatient psychiatric facilities. I see a lot of young people who are some of whom have co-occurring mental health conditions and are coming out of inpatient psychiatric facilities. And I always remind myself, the first time I'm seeing them after that, I don't need to fix their entire, I don't need to try to fix their entire mental health condition. Really, I'm just making sure that they're safe and trying to start a relationship so that we build up some trust and that we see people back. And so I think that's one of the approaches you can take in this situation also. One of the other things that seems to help is not just saying you're concerned about risks and benefits and alternatives, but doing something that shows that you have that you're concerned about their safety. And one of the things you can do that really shows you've thought about this and that you're that it's not, we're not just kind of parroting the party line or whatever, is providing some naloxone education and making sure that we prescribe, opioid reversal medications. I think it's hard if you say to someone, this is so dangerous. I really am uncomfortable. But then don't do anything to mitigate that risk. I think it creates a little bit of cognitive dissonance in people's mind. And so I try to have that discussion of like, I know this is working for you. We know there's a little bit of risk in this situation. I want us to do everything we can to make sure that you're safe as we build this relationship and figure out the next things we want to do. So in general, a couple of the simple things are sometimes some of the hardest, which is, I think especially, when the opioid crisis was really like ramping up, and this is like when some of us were younger, we saw the answer a lot of times is stopping people's opioids, to be honest. And I'll put myself having made that mistake a number of times also. And it's just that there are some downsides and you need to acknowledge that. And, you might see people who already have been cut off or have run out of their prescription before they get to you. And a few of the downsides are that it's often a trigger for misuse of other opioids. So people borrow from friends, they use things that are not prescribed to them. Sometimes it can even be a situation where it can trigger people to go out and seek opioids in other settings. And sometimes even in very unsafe type situations where they might not have prescription quality medications. And nowadays, we know that if people are buying opioids in a non-pharmaceutical kind of situation, it's often fentanyl. And the people who sell drugs are not always great at math and weighing things. And so small mistakes in fentanyl dosing can have really, drastic negative consequences. Also important to know that just because people have developed tolerance and experience withdrawal when they stop opioids, that's not the same as an opioid use disorder. That happens to any of us who take opioids. If I took opioids for a couple of weeks and I stopped, I would feel bad. So all of us would. It's just sort of biological tolerance. Really what defines a substance use disorder is like all the negative consequences that come with it, right? Like compulsive use, being unable to stop, using it in unsafe situations, or even when you don't want to. So, sometimes people will be labeled as having an opioid use disorder because they present with evidence of withdrawal or tolerance, and that's not always quite the full story. And so it's important because, some patients will really be turned off if they're sort of categorized or their chart notes say that they have an opioid use disorder and really they have been taking their prescription medications as prescribed. That can really also create, a situation where relationships are hard to grow. And then for benzodiazepines, similarly, abrupt discontinuation is dangerous, increases morbidity and mortality. And so even sometimes when I get things that I really do not love, I will continue these medications until we can come up with a plan together to get to a safer approach. And for those of you who've done a lot of benzo tapering over the years, it's just like, it's kind of tedious and boring, and it can take a long time. And there are many different ways to do it. And, some of you probably use the Ashton protocols, which is like, good old fashioned one that still works great. ASAM is coming out with some new guidelines on benzo tapering, but all of these are long-term approaches that require a relationship because you're talking many months at a minimum to decrease doses or change people around. And so I think these are the more specific risks. So for opioids, there's potential increase of overdoses and suicidal thoughts and even really negative mental health outcomes that happen when people are abruptly stopped. And similar with benzos, there can be increase in suicidal ideation, non-fatal overdoses, and ED visits compared to compared to maintaining people on stable long-term benzos, as long as you know what they have actually been taking. And so I think the other piece we need to talk about is just like risk mitigation. I think this is one of the areas that maybe we don't often talk about as much, but I know it's in the back of many of our minds as clinicians, which is like, man, I don't know if I want to put my name on this chart. Like I don't like this combination of medications or this dose of medications or this medication for that indication. And I don't want that to be a reflection on my care. And that's one thing, but we also worry about legal risk if something goes wrong. And I think in some ways, the good thing is the patient-centered approach, which is often like slowing our roll a little bit, building a relationship, maintaining the status quo for a short amount of time until you can build some plan, is not only patient-centered for lots of people, it's also, closer to the evidence that we have now in terms of risk when we stop these medications abruptly. And so everyone does this differently. I encourage people to come up with their own little dot phrase or something that they put it at the end of their notes in these situations, but essentially something that says like, you've had a thoughtful discussion with the patient about the risks of the medications and the potential benefits, and they're going to want to have that discussion about what benefits they see that they've derived from it and what alternatives there are. It doesn't necessarily mean that you need to embrace those alternatives today, right? And the alternatives often involve tapering medications, switching formulations, using safer options like buprenorphine instead of full agonists, often trying not to use opioid and benzos together, monitoring doses. All those things are, harm reduction type approaches to these medications that I think it's smart to take a little time to document. In all these situations, I don't write them for people, but I encourage people to write out their own and really actually have that discussion with patients. I think that is probably more valuable upfront, like setting some expectations about, showing that you care and that you're thoughtful about the risk. You're prescribing naloxone, so it's obvious that you're concerned and that you're doing something about it, and then setting up a plan for follow-up. A lot of the situation where a clinic closes is sometimes a little bit more chaotic in terms of medical records. A lot of these that we deal with on an individual bases are because, a clinician retires or someone loses, they had a really unsafe prescribing practice and they lose their DEA, or those kinds of situations are more like one-offs. When it's a whole system that kind of like implodes a little bit, sometimes it can be hard to get information, hard to get records, and that's where we just encourage people to lean on the PDMP to get an accurate picture of the doses. This is again just grain of salt. I often try to get an idea about the functional status of patients on that first visit too. I just want to kind of have something to compare things to in the future in terms of how much activity people are able to do, what kind of things in their life they're able to do, what their perception is of what they can do with and without different medications. Just kind of get that down so that I can refer back to it later. I find that personally more valuable than like a really detailed like history of all of their pain and all of the different procedures they've had and all of the different things that they've tried. I feel like those can happen at future visits, and it doesn't impact those early decisions about risk and safety very much. But I do like knowing what people's functional status are, because a lot of the medication changes that you might make in the future hopefully are based on people's functional response to medications, not just necessarily feelings and emotions. So I threw this in last minute. I probably violated one of Sarah's rules about the slide modifications, but I just wanted to highlight this because I think we all know that this is difficult, right? It can be very tough the first time you're meeting someone to figure out like, is this is this straightforward chronic pain? Is this someone with a underlying opioid use disorder or other substance use disorders? Is it somewhere in the middle, in that mix of, complex pain, opioid hyperalgesia, plus, some all kinds of central pain type stuff. And I think just having, I don't know if this, I'm not the person who gives permission to do anything, but I think maybe when we take a lot of consults, right? I do a lot of consults around the state where people call with these kinds of questions. We often are getting called around like how to start buprenorphine or how to treat alcohol use disorder, whatever. But it's actually really common for us to get calls around like, I inherited this patient from my partner who retired, and I looked at their med list and I freaked out. And I think that's like a normal part of it. And people often have a good plan in their own mind, and they almost feel like they need a little bit of a permission to do it. So I'm hoping that I'm giving people permission to like slow their roll, often try to work on the relationship part and not burn bridges early on by keeping people on stable regimens, but mitigating risk as much as possible, and then coming up with a long-term plan. The good thing is if people do have opioid use disorders that are uncovered during these processes, or chronic pain that is not responding well to opioids, there are a number of other choices. And some of them are actually good for both, right? Like we use a lot of buprenorphine for opioid use disorder, but actually buprenorphine for opioid responsive pain also works pretty well, and it's often a lot safer. And there are newer formulations, including like some patches and other things that can be used. One of the things I hope you take away from this is that there's a lot of help in situations where people are feeling uncertain about next best steps. And I'm really glad that Corewell has a group that's trying to provide some support, and certainly our group also does that. Tuesdays you get me, other days you get other people, but a lot of people who have a lot of experience at the intersection of pain and substance use disorders. I threw this one in here too, just because it's my baby. I told Chad I was going to take it out, and then I put it back in. But I do get lots of questions sometimes about, how do I tell if someone has opioid use disorder or they just have chronic pain that's not very well controlled by their opioids. And I just wanted to use this as a reminder. Just probably some people on this call learned this in medical school, but there's not a lot of teaching on this is still in medical school. So I'm not surprised, if people haven't seen it or have forgotten it. But the real focus for identifying opioid use disorder are these other things other than tolerance and withdrawal. So asking people about cravings, if they're having cravings for their medications, if they're having compulsive use, like using more than they intended or more frequently than intended. And then if they've had any loss of control of their use, where they've run out early or they're using some from a friend or family member. And then this negative consequences is one of the real key features of substance use disorders in general. It's like when you know something is causing problems and you keep doing it, is one of the signs that people have maybe a problem that's a little bit more complicated than just chronic pain, although that can be very complicated, but a problem that you might need to address in a slightly different way. So I just wanted to plug our consultation services from Open. I know Sarah had mentioned it, and it'll be in the slide set. But we offer same-day consultations all during the week. We have a mixture of addiction medicine folks, primary care doctors, people with experience in obstetrics. We have pharmacists, we have hepatologists who helps with hepatitis C. We have a really diverse, multidisciplinary team, and we can get you, if we don't get if you don't happen to, if you hit me and it's a question that's not right up my alley, I can help people get to the next person who might be able to help. And it's pretty easy to access, and we try to get back to you that same day. And oftentimes, I think oftentimes we just listened to the story, and people often have a really good plan on their own, but sometimes they just want to run it by somebody else if it's not something they do all the time, or if they're working in a setting where they don't have other colleagues that they can just immediately grab and say like, what do you think about this? What would you do in this situation? So I'm hopeful that we're going to have a good time for questions. I know Chad and Sarah are um, working behind the scenes, seeing if there's any Q&A. Hopefully the questions won't be too hard. I'm going to take the easy ones, and I'm going to send the hard ones to Chad.
Thanks, Chris. That was great. I really appreciate it. I think I want to just come back and sort of like, if somebody walks away, they're coming by a colleague in the clinic today and say, oh, what was it about? What was today about? And I think if I was to summarize it is, like this is a challenging situation, but most challenging for the people affected, the people using opioids and benzodiazepines, and the short-term goal, if you're seeing one of those people today or tomorrow or whenever that is, I think that the short-term goal is to stabilize that person, even if it is extending beyond your normal prescribing, right? So even if that is outside your norm, that acute disruptions, denying that person opioids, it just really can cause its own problems and its own mortality. And I think that I would encourage people, as you said, to document well. You can document, this is outside of my normal prescribing. This is atypical for me, but this is the reason why. You do want to check the PDMP to ensure that it's there, and you do want to potentially you do a urine drug test just to make sure there's nothing else there. But I think it's really important that you stabilize people, and that might happen more than once. In other words, it may not just be you see the person in your clinic once, I'm going to do this once, but I'm not going to do it again. That kind of creates a threat situation that the person is now on their heels, you're in control. You're trying to create a relationship. Every time I'm in the clinic, I prescribe opioids. Every time, right? It is part of the care that I provide for chronic pain. And I think to this first question, because this came from one of them, I've seen a couple of the communications about this mention the CDC guidelines. I believe in the CDC guidelines, but talk to me. Is the CDC guideline really the best point of reference for one of these patients who comes in to your clinic tomorrow, Chris?
So I always think of the CDC guidelines as a really good place to start when you're considering what to do before you consider starting opioids, right? Like making sure that you're doing all of the non-opioid things, that you're really talking about the risks and benefits, that you're considering dose and formulation, and really looking at the evidence that lots of pain is going to not be as opioid responsive or long term, and that there are potential downsides in terms of exacerbating pain in the long run. So I think of it as like an upfront. Once people are on stable doses that they've been taking for a while, I think they tend to be less helpful because it can create a little bit of almost like a anxiety in clinicians, like, oh, I'm not following a guideline, when they're really not designed for this situation, where you're inheriting someone who's already on a regimen that may have taken them a long time to get there. They may already have tolerance and withdrawal if they stop. And the guidelines really don't take into account some of these the negative impacts of abrupt discontinuation, although they do, for the most part, recommend not abruptly discontinuing these meds. So I think it has a lot of good things in it, but it's not probably the first place I'd go in this situation, just to look for help.
Right. So it's really more leaning on the CDC guidelines as you develop that relationship over time, thinking about that. But it's not really a day one conversation, right? That you may deviate from CDC guidelines. And again, I hate to make everything medical legal, but people are anxious about that, right? And I would say if you're concerned, and this is true of any kind of practice, whether you're talking about opioids or anything, just document well. I think, where we see problems medical legally is when a person does something that's outside of their own standard or a typical standard of care, and they don't document why. If you document why and you provide a reasonable rationale, there's a lot of things that are, okay, if you will, right? Because there's a wide standard of what's reasonable. We got a couple questions in the chat. One of them is around methadone. And this is, it says, can you address for non-addiction specialists the safety of outpatient methadone? I certainly use methadone in chronic pain patients. I don't know if you want to address that. I'm happy to talk about it as well.
I'll give my answer, and then Chad can give the right answer. I think obviously there's been these waves of differences in terms of generations of clinicians, right? So like when I was doing residency, methadone in primary care was fairly common for pain. It has some advantages, right? It's long acting, has fairly good for nociceptive pain. There's all these things, but the downsides are that it's variably metabolized by people. The doses can build up. If people are not taking it as prescribed, they can get a dose stacking effect where they can really get into trouble. And a lot of the early overdoses, specifically deaths, were due to methadone. So I always think of it as an oldie and a somewhat goodie. Definitely great for opioid use disorder and outpatient treatment programs. And sometimes a good choice for chronic pain, but user buyer beware. And it's one of those medications where I think it deserves a little extra attention to detail in terms of making sure that you understand dosing, pharmacokinetics, and how your patient is taking medications. I would never start it for someone who I didn't have a good understanding of what we were doing with. But in this situation, I think the PDMP can be quite helpful because you really can see what people are taking, how much they're taking it. And I would agree with Chad. I often think of urine drug screens as, how do I put this? I think sometimes clinicians use them punitively, right? And I always, in the back of my mind, I just always say to myself, like, this is a test I'm doing for the patient, not to the patient, right?
That's
right. But for methadone and benzodiazepines, I do like to know what other things people are taking because I do think there's a little bit more risk. I don't know, Chad, if you have other thoughts on that.
Yeah, I mean, first of all, just echo your concept of the urine drug test. I mean, it's intended to enhance safety for the patient. I think that the providers out there who are using it purely as a gotcha moment to withhold medications from patients are missing the point. It's a safety thing and it needs to be used as such. When you find something you're not expecting, you have a conversation, you document, and I think each situation is different. It'll be impossible in a webinar to explain the entirety of all the different options, right? But using good clinical judgment and being empathetic to the person, I think if you're using UDTs just to figure out who you can sort of cut off and release, that's a mistake, right? So here the UDT is, I think, both to assess safety, and then in the case of, and I'll get back to methadone, but you brought up UDT. The UDT, urine drug testing, that urine drug test is in part to make sure that the person's actively using their medications. So if you have one of these people, we say there's about 3.8% of the people on 90 milligrams more. We are hearing, and there's a comment in the chat that some people are already being cut off, not being able to see providers. You may see that person and they may not have, if let's say, for example, they were on oxycodone. Their urine drug test might be negative for oxycodone, but their PDMP clearly shows they were getting month-over-month oxycodone. You may have medical records to show that they were using it. And when you sit and talk to the person, says, yeah, I was using it and I'm out, right? And I don't think that means you don't rewrite it, you don't put it, but now you want to be thinking about safety, right? How long have you been off of this? We've seen this with people more in the opioid use disorder space when there is a period of recovery and then relapse. If people go back and start using the same amount they were using before, they see higher rates of overdose, right? Because your tolerance can change. Now, tolerance doesn't change that quickly, right? So if it's been days, putting the person back on their dose that they were on before might be the safest thing you can do for them. But again, have a conversation, use good clinical rationale, and document. right? And I think that that can be so that urine drug testing is important. Methadone for chronic pain, it's not my go-to, it's not my first case, but I can think of multiple patients off the top of my head, people I'll see today who are on methadone. And I think it has some advantages of being long acting. There are some different pharmacology that there's different pharmacology that I really won't bore people with, but there's a potential reason why it would be better. Again, it's not my first choice, but it's something that sometimes people sort of graduate to. And sometimes I even use it in some of my older patients, really low doses, because it just hangs around a long time. And so I have found that to be helpful. If you're seeing people who are on it once a day, that's an indication and at a high dose, that's an indication of a person who is getting it for opioid use disorder. That will not show up in the PDMP, right? And you don't, as a non-addiction provider, you can't really, engage in that care. That is for their addiction service. And so I think that's a different situation. That should not be disrupted here, though. This was not an addiction clinic. This was a pain clinic. We have another question here, and I think this is to the point of why we're having this today, right? Like, this is one of the bigger disruptions I've seen, and it doesn't surprise me that people are struggling to find care. We've had great conversations with these clinics in the west side of the state, these hospitals in the west side of the state that are trying, but they are hearing. Our phones are overwhelmed, not only for calls for medications, but for general pain care, procedural care. They were getting procedures before. And so it's just the total volume. And as you can imagine, with that volume of patients, it's going to take a while for this to shake out. So the question is, where do these people go? What do they do? And a few things I would say, if they have an established primary care physician, they should go to their primary care physician. That I realize that may not be an easy answer, but it is one that is a first step. As I said, Blue Cross Blue Shield of Michigan we cross-referenced Michigan pain consultant providers to Blue Cross patients, and all of their primary care physicians received our communication, basically explaining the situation, exactly what we're talking about today, and encouraging those PCPs to see those patients and manage their care. That was very direct, very active. And then I think, Michigan pain consultants themselves have listed on their website at least 4 of the physicians and where they're going. Would encourage people to go onto the website and see where those providers are. While the clinic went bankrupt and is closing, it doesn't mean all those providers are retiring. Many of them probably have lives in Western Michigan. They're going to end up somewhere. And, I think the hardest part right now, and I'm really empathetic to this, ERs are really challenging places to get that kind of care. It's the place where people are going to feel most stigmatized, least wanted, least cared for, and it's going to be the most challenging situation. So for right now, I think this is why we are really hoping and appealing to primary care physicians. I will say open is we are interested in hearing from PCPs on what else could help. And just know that Corewell Health, who, while not, Michigan Pain Consultants was a distinct entity, there were clinics that were within the Corewell system from Michigan Pain Consultants. Their pain physicians and primary care physicians are doing other work, as are other pain clinics in the area. And so I guess it's an issue of persistence. I didn't come onto this webinar today expecting that we would have every fix, but we hope that what we're doing is empowering PCPs to take these folks on, because ultimately, even if we wanted to, there's not enough pain providers to do this. There's another question here. Is there any data to indicate how many of the people with this clinic closure are on services for pain management versus OUD? After stabilization, is it reasonable to move them to alternatives to opioids, including non-pharmacological interventions? And so I'll take it in 2 pieces, hand off to you, Chris, to follow. But our sense is that the majority of the care here was for chronic pain. When I look at the data, we don't actually see much in the way of OUD medications or any, right? I don't get the sense that this was treatment for opioid use disorder. So I don't. Now, within that, though, I do want to acknowledge, and I believe this to be true, there is a portion of the population who use opioids for chronic pain who have opioid use disorder. I don't think that means that this is not, as Chris mentioned very eloquently, simply withdrawing doesn't mean if the person has opioid use disorder, or simply having, some of those, withdrawal effects does not indicate OUD. Moreover, that first encounter is really not the time to take a person who's been on opioids for many months or even years and say, look, I really think you have opioid use disorder. And today's the day, as your new provider, brand new to you, to this care, where I'm going to quote fix it. You need to put them in a safe situation. Maybe you're going to talk about naloxone. You're going to assess for other co-occurring substance use disorders, but you do not want this to be the day that you're going to go hardcore. Here's OUD. And to the second question, and I'll let Chris answer as well. Yeah, I mean, I think it's always reasonable. Pain is a disease. It's not a symptom. Many people will live with chronic daily pain for life. And I think we should always be reassessing our medication options. But I don't think it's always because we always need to or want to get people off of opioids, right? If a person's clearly not benefiting, they're clearly showing some signs of adverse events or adverse effects of opioids, that might be a time to talk about it. But when a person comes into my clinic and they're on opioids and they're using opioids for pain, and they're naming them as effective, and we have that conversation, it's something we evaluate, but it's not necessarily my highest order of effect. Am I going to look at other things that might help them? We do interventions. I think those sometimes can help, sometimes they don't. And there are always non-pharmacologic things we consider, but I don't necessarily think everything has to be about getting the person off of opioids. Chris mentioned very clearly, this is acute stabilization and then long-term planning. Chris, do you want to, did I miss anything there?
No, I was just going to say that, early on I agree completely. Early on, often I'm looking for areas where there's maybe like a discrepancy in people's description of their functional status and their relationship with medications. So I think it is helpful to try to like make a little mental file. Like if someone says to me like, oh yeah, it's I feel better when I'm taking opioids, but constipation is killing me. Or like I know I'm not sleeping well because of this. Or I don't feel sharp when I'm playing with my grandkids. Like I'm really tired a lot. I won't maybe use those right then, but I do file those away. I just kind of make a little note in my note because in the future, when it comes to talking about safer alternatives, I'll often try to re-anchor on those things where maybe there's something that is not going great for somebody, and that there might be either both a safer choice and something that's more effective. Like I'm always surprised at the number of people who actually do better, right, when they're tapered off, say benzos or some of the full agonist opioids. And it's not always, but some people really like they haven't felt unmedicated or in one of those ways for many, many years. And sometimes people do actually feel quite a bit better. And I'll tell people that, but I agree, not the first day, because no one wants that message the first day. They're terrified that you're going to abandon them, right? And that they're going to have to go sit in an ER somewhere and try to talk somebody into continuing their medications so that they don't feel terrible. And that's not good for anybody. It's not good for the ERs, not good for the patients, and really not good for long-term relationships with primary care people in the community. The one thing I did want to touch on is the idea of follow-up. So I think that's a common question is like, well, okay, we got through that first day, like, but what next? And if there was, I do not have an easy button. If I had an easy button, I would like just live with my hand pushing it. But I do think early on in a relationship, it's smart to see people as frequently as you're able to within the sort of constraints of your practice. And try not to do a ton of work for free, to be honest. Like I think it makes good sense to bill based on time in these situations. Good reminder that 99215 is 40 minutes, right? And that's not 40 minutes with the patient. That's 40 minutes total, right? Like including the time you looked at their chart, their PDMP, that you thought about what you're going to do, saw the patient, and finished your note. And so if you have capacity in your system, I think it's important to like see people frequently, get credit for the work that you're doing and the expertise that you bring, and see people quite frequently at the beginning so that you can both make sure that you're doing your due diligence in terms of making sure you're documenting, checking PDMP, checking UDS if you need to, all of those things, and that the patient's starting to trust that you're not just a one-off person, but also setting some good boundaries around what the expectations are when people are using controlled substances in your practice.
Thanks, Chris. We are coming up on the hour. We do have a question, and I think this is I wish again that I had the easy button. The comment is that this is not really what's happening. I think this is happening some. I will say, I mean, I don't know how often, and there's no way to quantify this, at least not, we don't have data live enough to do this. We will be looking at this afterwards to kind of see what happens. There was a question earlier about like what's known about these situations, and very little is the answer. And so we're going to try to help close that gap a bit. And I know other groups are studying this as well. But I think the situation where the patient sees a new provider, the new provider says, I'm not going to do this, and you have no say in the matter, is incredibly hard. I don't have an easy answer for this because I'm not contesting that this is happening. I think that's the purpose of us doing this today. I'm sorry we couldn't do it sooner. I will say, I think that, some of this now, having gone through this in a large wave, it will be part of what Open does going forward, is to start to try to better assess these situations of acute closure. And this is work we've done, but maybe will be an expanded part of our efforts going forward to try to better educate our primary care community in particular, who I understand the concern, and I'm empathetic to both sides of this, but ultimately we'd love to see people stabilized. I think for right now, how I would advise the people who are in this situation would be to try to connect with one of these Michigan pain consultant providers who's going to another clinic. Again, that's available on the website. If they're within the Corewell Health system, their primary care physicians within Corewell Health, I would encourage them to do that consultation and or have their primary care physician consult us. I think it's hard. You don't want to tell people, I think that relationship, we've talked a lot about how we as providers need to be careful not to sort of start the relationship off on the wrong note. I think it's equally important, as with any relationship, that both parties come in engaged and try to do that. And it's hard to ask because people are scared and anxious and frustrated, and it's really easy to understand why. And I'm really empathetic to that, truly. But I think ultimately, if there's one provider that's just not going to do it, it's about finding another provider. You can call your insurance company. Blue Cross is trying on this. Unfortunately, this is not a big. A lot of the private insurance in that area is not Blue Cross. So, we will continue to try to educate, work on this. We're going to disseminate this webinar, and I'm going to wrap up here because we are at the hour. Thank you to all the folks who attended. Dr. Frank, thank you for providing your expertise. There's not a lot of primary care physicians out there that do what you do. And it is really terrific and helpful to have your expertise, not only today, but in that consultative service, which again is open for physicians, sort of peer-to-peer consultative services. It's a unique thing that we offer within Open to try to support communities. Again, you can go to our website, michigan-open.org. Thank you to Sarah and the Open team for all that they've done. And we recognize this is a challenging situation. We are open to suggestions on other things that we can do. We have an email address within the Open website, and we'll be open to feedback, information, or anything positive, constructive that we can do. Great.
Thank you guys both so much. We'll go ahead and end the webinar, and everyone, attendees, look for a follow-up in your email for CE and the recording. Thank you.
Thank you.
Bye.